And so last but not least, we're going to hear from Shai Lauros, who will provide her perspective from the nonprofit sector. Shai has worked in the private, public, and nonprofit sectors and has been trained as both an architect and a planner. So please welcome Shai.
Thank you. So the interesting thing for today is that we were just hearing about real estate development, private developers, and I'd like to just ask the audience, could you raise your hand in the audience if you are a developer? I'm alone here. Now, I come from a nonprofit developer background. So there are a couple different ways to approach development. And I also wear many hats. So I bring development, but nonprofit development, into my work. And my work is community development. And in particular, the health elements and the health intersections of development and community development. So the one thing that before going into my presentation, I just want to note is that I think that actually all of you are developers. You're just nascent. You don't know it yet. And what I want to encourage considerations of today and going into your conversations tomorrow is that you don't need to wait for private developers, for school developers, for experienced developers to develop in your community. That you can take the initiative to do that yourself. So I'm going to talk a bit about how we bring health and community development together and how we support initiatives that may be built, that may be development typically perceived, but are other forms of supplementary, complementary programming and initiatives and policies that are really inextricable from development. So when I think about development, I think about actually the confluence of all of these things. And that really gets into a lot of the conversations that folks have had today about the comprehensive nature of the work, right? We talk about complete streets, or we talk about well-rounded partnerships. So I just want you to be thinking about some of these ideas as I move forward. My name is Shai Lauros. I am the National Director for Health for the Local Initiative Support Corporation, also known as LISC, from LISC National. And I'm thankful to be able to participate today in this conversation. I want to talk about what LISC is. There are some of you that are familiar with us as an organization and some of you that are not. So we are a community development intermediary. And as you follow these arrows around, you'll see that what we do is you bring capital investment together with technical assistance, technical resources, to build the assets in the local capacity of communities. So think financial institutions, banks, philanthropic entities, charitable organizations, as well as the public sector, on all levels, federal, state, municipal, city, with community development corporations, community action agencies, community-based organizations, and real estate development organizations, both public and private. I talked about the difference between a nonprofit developer or a private developer. There are also private developers who have a very nonprofit-driven mission, and likewise, there are nonprofit developers that have a very private developer, stereotypically driven mission. We have two arms within LISC that are our subsidiary entities that do syndication, financing, New Market Support Corporation, and NEF, or National Equity Fund. So LISC has been in operation since 1980, and that's resulted in 350,000 affordable homes and apartments, 56 million square feet of retail and community space and growing, and $16.2 billion invested, leveraging approximately $48.5 billion total development. And the type of partners that we have, I mentioned briefly a moment ago, but they really range. We work with Facebook, Disney, Under Armour. We work with all levels of nonprofit organizations and NGOs, so public, private, nonprofit. And what we do is we bring them together. So we look at community development as a form of transaction for transformation. And the community development approach that we have involves bringing local leaders together with residents, addressing the physical, social, economic needs of a neighborhood, and facilitating those cross-sector partnerships while also assembling investment in order to pursue the work. So public and private capital. And it is for usually high-risk investment. So we all know that the market doesn't always provide what is needed by a neighborhood. It's the concept basically of economics and public goods, and that there is a role for someone to step in to facilitate that to happen, and that's what we do. Projects that are more difficult, more complicated, especially financially in terms of the products or transactions, but also in terms of whether or not there's going to actually be a return on investment. When we talk about health, we mention throughout the day a bit the social determinants of health, and that is the sphere within which we're working. That obviously means more and more working with all different levels of the medical industry, the pharmaceutical industry, but it also is heavily focused on the built environment, housing, facilities, infrastructure, amenities, economic vitality, workforce development, small business, employment and jobs, employment persistence, asset building, financial coaching, financial literacy and planning, the human capital, education, early childhood, training, wellness and safety, and social capital. There was conversation earlier about social isolation, very much key in terms of driving determinants for health, thus engagement, organizing, leadership, participation. And so we look at a place as a way to bring all of the elements together, to not just work comprehensively, but to leverage each other's effects for sustainability. In other words, you can't continually subsidize communities. You can't continually subsidize any type of work, of course, but what you can do are two things. You can implement the best practices that will actually allow for more sustainable continuity, and you can allow for revenue generating opportunities that will supplement and support community development, perhaps in perpetuity or at least at a longer term than the short-term intervention. So I'm going to talk about one example of a strategy. Now, we've talked about how there needs to be cross-sector collaboration, there needs to be strategies, there need to be thoughts of innovative strategies. I'm going to talk concretely about some that we've done. And I'm going to talk about our Healthy Futures Fund initiative, HFF, because it's a little bit of a tongue twister. So what we did is we brought together a few different entities. We worked very closely with the Kresge Foundation, Morgan Stanley and LISC, and Dignity Health joined in a bit later. We have a phase 1 and a phase 2. And that meant that we pooled together $200 million for investment. And then we dispersed that in very targeted initiatives across the country. And I'll stop here to just talk a bit about our geography. So LISC looks at the country as our footprint, our catchment area. We have local offices in 31 cities across the United States and growing. And we work in 2,000 rural counties across about 44 states. So that investment pool is designed to basically address both the rural, urban, suburban, ex-urban, all of the spectrum. And the low-income housing tax credits were also a key driver in this. So we used new market credits, we used LIHTC, and then we brought in other types of funding and financing and gap bridging tools. So the major thrust of this was about co-locations, right? That we were trying to bring together initiatives that would have a greater health impact than them, number one, on their own, and number two, most importantly, intention. So really intentional, targeted development. That means being able to articulate outcomes and impacts, tracking and evaluating them. So you can't set goals that you're not able to then determine whether or not you've achieved them. And this evaluation is very tricky. So we've seen data sets this morning, and the fact is that in the, someone made a comment about that it's not rocket science, but rocket science have data and numbers that are very hard, and you can follow the algorithms and come to a very specific point, a coordinate. And in social science, you have this mix of qualitative and quantitative data, and even in medicine, you have so many unknown variables that you're not yet able to quantify. There aren't algorithms to bring all of the permutations of impacts together. So both in the field of medicine, and this transfers over into the field of health and community development, we're not there yet to be able to determine causality. So we're making these initiatives, and we are tracking and evaluating, but I want to note that we're very conscientious that it is difficult to determine causality, so we're using some interesting evaluative techniques to be conscientious about that. The last thing I'll mention before I go to the next slide actually is that we did use grants to support capacity building and collaboration. So that meant that there was technical assistance in planning and bringing together partners. And some of these partners are still navigating their relationships as the plans are being developed, even as the buildings are in construction. They're still navigating their relationships and partnerships and on into operation. So there are examples of this where you have a plan, it's something of a hypothesis, you test it, it's piloted, and then you tweak it, right? So we're evaluating, tracking, adjusting, evaluating, tracking, adjusting. So a couple examples of this. Vincenze's Supermarket in the Brockton neighborhood in Massachusetts. This was a grocery store co-located with a health clinic. And what's interesting about this is that there is a collaboration in terms of the type of programs and initiatives that are jointly developed and monitored between the two. Cooking demonstrations, guided shopping, and a rewards program for healthy food purchases, health prescriptions and such. And then I wanted to bring another example. This is what I call health intent housing. So using health impactful initiatives for comprehensive community health. And the idea is to try and get as much out of an initiative as possible, right? So what's interesting here are two things. Number one, as I talked about developers taking initiative and that being actually community members or those that are concerned about the community or neighborhood in which they're in. In this situation, the actual health department is an owner of this development. And the housing authority is also an owner. Now, technically, they're an owner through a subsidiary, a sort of nonprofit / development arm, essentially an HDFC. But the fact is that the city itself needed a development done, and they took the initiative to do so. In addition, because of the work with the community to determine what they needed in this area, knowing well that the issue of assisted living and the lack of housing for seniors was an issue. But in the further conversations in the community, they realized that what they really needed was actually a pediatric clinic. So what happened is the clinic that is for the seniors of the assisted living facility is now also open and operating as a pediatric clinic. A few more examples of health components in projects. Washington, D.C., right here. So others may eat. This is a mixed use, and what's interesting in this initiative is the bringing together of youth activity, recreation through the National Baseball Hall of Fame we worked with for youth education, and also a high-performance green building with retail amenities and affordable housing. In Georgia, in Chamblee, there's senior residences at Mercy Park. I wanted to highlight this despite the fact that it's also senior housing. It has 13 fixed and mobile primary care clinics, and so it offers the services directly to the housing tenants. However, it also meets them where they're at. It doesn't assume that they will all be able to come to the health clinic. And then the Neighborhood Health Association Clinic in Toledo. This is interesting because it actually is a very comprehensive approach to a health clinic. In other words, it took many different health clinics around the city and consolidated them. So it was in part an expansion because the needs were so high, but it also was a way to bring together a existing homeless clinic, a women's health center, a credit union to be able to bring in the financial planning and financial literacy components and address the workforce development components, community gardens with a particular focus on promoting fresh and healthy foods and eating choices, and a subsidized pharmacy. So that with family and adult medicine, you have many components of what's needed by the community. The other thing that LISC does is it brings together various partners on the ground, in particular community-based organizations, and their nonprofit partners, their public institution partners, academic institutions, health institution partners together to take on new initiatives for a greater health impact. In New York City, we worked with the Tisch Foundation for the Communities for Healthy Food initiative, which integrated multiple healthy food strategies. And we also have initiatives to use existing data and programs. We have the Robert Wood Johnson Foundation County Health Rankings Project. And so in Boston, Indianapolis, and Philadelphia, we worked to create new planning initiatives that coordinated multiple nonprofits working on similar issues, or in some cases the same issues, but that were not coordinated, that were not having conversations, not even about best practices, lessons learned, right? So we brought them together, had them look at the data and figure out what were their next steps using the data and using their partnership to move forward for greater health impacts. And we offered them coaching through a consultancy initiative. And I want to point out one particular example, which is the Home Preservation Initiative in Philadelphia, where they addressed deferred maintenance and they addressed issues relating to pests, mold, indoor air quality, to not only counteract the disinvestment in the neighborhood and to bring a renewed sense of dignity to a neighborhood, but to also think about how residents can have housing stability. Because housing stability has been the #1 issue stated when patients go and they speak with their hospitals and healthcare systems. They want to talk about, for example, a loss of hearing that may be noticed in an appointment. And just now, as they see this data, the physician, they want to talk about this issue, right? This is a critical issue. You're losing your hearing. Hearing is not my issue right now. I might not have a place to go after I leave this appointment, right? So how do you start talking about health issues if you don't have your basic foundation of a place to sleep each day? Now, the last slide that I'm going to use to talk about some of these issues is around the public health agencies, which we heard from already, and the hospitals and healthcare organizations. So there are new and renewed partnerships across the country that's happening, and I just wanted to highlight a couple. The coming together of community development organizations and health is still in its infancy. And as coming from the community development side, I would say that we haven't done enough to be able to push on that partnerships, because we reach out to those that are willing to work with us, that come to work with us, that know us, that we're trusted and valued in a community. But for a multitude of reasons that we probably don't have time to get into today, that hasn't happened as much with hospitals, local hospitals, and with those healthcare institutions in a neighborhood. So we're trying to bridge this divide and move forward, and not just for the funding potential that it provides, which has been mentioned, and you think of the typical anchor institutions work, but also for the new opportunities that it brings by tapping into essentially untapped resources. So in New York City, the Department of Health worked with LISC to initiate integrated pest management, which addressed a variety of issues, as well as smoking cessation and active living. In Rhode Island, the health department initiated a health equity zone initiative with extensive community planning. In Richmond, in California, commercial corridor revitalization. This is one of my favorite initiatives because the fact is that a hospital/healthcare system realized how important commercial corridors are to a neighborhood and actually invested in it. And then in Twin Cities, there have been very grassroots initiatives with citizen health action teams and the health department. So what I'm bringing together here is place, programs, and policy in order to impact the health of an individual and a family. But I also want to highlight that what we're trying to do is focus on place without too much of a focus on place. Because when you talk about health equity and you talk about equitable development, you cannot remove yourself from the positive as well as the negative externalities that can come with that. And there's a host of them, but one of the ones that we wanted to focus on in our panel today is gentrification. And in the conversation of equity right now, while there are extensive and I think progressive movements around racial divides and around geographic divides and tensions between rural and urban, there's also a lot of opportunity to do things differently. There's opportunities to do things differently around Harvey and Irma in rebuilding, things that didn't happen during Katrina, where there were conversations about sustainable redevelopment that hopefully can happen now. And that communities need to start addressing gentrification 10 years before they think they're going to have to start working on it. And I've had cities come to me in providing consultancy that they don't need to worry about gentrification. They're just starting on their path. I said, you won't be able to worry about it later. It'll be too late. So we have to be thinking about it very early, or early and often, as they say. And we have to think about income, because one of the key issues around obesity is income. Can you afford to purchase the foods that you need to purchase? And family. When we talk about the different layers of peeling back the onion, family is as much a zip code as is place. People point to obesity as an issue of location, and it is. There's a correlation between zip code and obesity. But that correlation also follows poverty indicators and the income diversity of cities and neighborhoods. So in closing, and we can have more conversation going forward, when we talk about equitable development, I think we need to merge the conversations of equity in health and equity in development, workforce development, social services, and real estate development. Thank you.